Hello, everybody, and welcome to CureCP.org's webinar series. We thank you for your attendance. I'm going to go over a few of the features of today's call and then introduce our guest host. First of all, a little bit about CureCP.org. I'm sure most of you are already familiar. We're a nonprofit organization dedicated to cerebral palsy research. If you want to learn more about us and how you can help us on our mission, you can visit us online at www.curecp.org. That's www.curecp.org. If you notice up, you should have a pop-up window, and there should be right next to the phone, there is a chat bubble. At the end of this presentation, we are going to have a Q&A session. So if you have any questions during the presentation, please click on that and send your questions to me, and at the end, we will ask our host to answer these questions to the best of their ability. Now, with that being said, I would like to introduce Daisy Christensen. She's a PhD of Epidemiologist at the National Center of Birth Defects and Developmental Disabilities at the CDC.
Thank you for the introduction, Jeff, and thanks to all of you for the opportunity to discuss our cerebral palsy activities and our latest findings. Next slide, entitled Presentation Overview. So I want to provide a brief overview of what I'll be covering during this presentation. First of all, I'm going to refer to cerebral palsy as CP during this talk. I'm going to talk about why CP is an important public health concern, and follow that with a description of our CP surveillance activities here at CDC. Finally, I'll discuss what we know about causes and risk factors for CP, as well as things that parents can do to help prevent CP. We don't have the answers that we'd like to for these latter things, but there are some things that we can recommend. Next slide. So cerebral palsy consists of a group of permanent disorders occurring in the developing brain that affect the development of motor skills and posture. It could be the result of an injury to the brain or a structural malformation. By definition, CP is non-progressive, meaning that the injury or malformation itself does not change or worsen. However, the way that CP affects a person may change over time. Next slide. So recently, the definition of cerebral palsy was updated to acknowledge that it's often accompanied by other challenges, such as disturbances of sensation, perception, cognition, communication, and behavior. In addition, epilepsy occurs in about 40% of people with CP, and the motor and posture disturbances of CP can lead to secondary musculoskeletal problems. All of these co-occurring conditions can present additional challenges to a person's ability to function and participate in the community, so it's important to recognize and treat these conditions in order to maximize functioning and participation. Next slide. Why is cerebral palsy an important public health issue? So on the population level, we know CP is common and costly. Using data from national surveys conducted by CDC, we know that about 15% of children in the United States have a developmental disability, such as CP, autism spectrum disorder, attention deficit hyperactivity disorder, a learning disability, things like that. Our most recent data on the prevalence of CP shows that about 1 in 323 children have CP. So it's important to remember that this is an average estimate. These data are important because we know that children with developmental disabilities, including CP, have increased needs for pediatric health and specialist services. These services are used to treat both the primary disability and the co-occurring conditions, which, as we just saw, can be considerable. We conducted a study using data from Medicaid that, not surprisingly, showed much higher medical costs for children with CP compared to those without CP, and other economic analyses have shown that lifetime costs associated with CP are high. Next slide, family perspective. So I'm sure I don't need to explain to many in our audience the impact that CP has on the family or individual level. I'm going to read a quote from a parent. Every aspect of our lives is shaped by the over 1,200 hours a year it takes to take our daughter with cerebral palsy to her more than 200 appointments with 9 doctors and 5 therapists, deal with insurance, find needed equipment and services, do therapy with her at home, address her behavioral issues, spend extra time on her schoolwork, supervise almost everything she does to maintain her safety and maximize her independence, and make the extra time for her to do things other kids do so quickly and so easily. By Sandy, the parent of a child with cerebral palsy. And to read more about her story, you can go to our website, www.cdc.gov/CP, where we have a wealth of information and some additional stories. Next slide, public health model. So here's an illustration of the public health model that we've applied to CP. Surveillance or tracking of CP is the first step, and it really is the bedrock of public health. Information we learn through tracking, such as the number and characteristics of children with CP, feeds into research on causes and risk factors. When the cause or causes of a particular condition are identified through research, we can intervene through prevention and treatment activities. And the cycle actually continues as the surveillance systems are critical in evaluating the effectiveness of prevention and treatment programs. The triangle represents partnerships which are necessary at every step. We do not do our work on CP alone, but we partner with communities around the country to do this tracking. Next slide. What is public health surveillance? So the concept of surveillance might be a new one for some people in the audience. Surveillance is the ongoing monitoring of diseases or other conditions within a population for planning and assessment purposes. So we, on an ongoing basis, in the same way every year, collect the same data, here, for example, on CP, which helps people in the community plan for services and educational needs for children with CP, helps us to evaluate and look for differences in risk factors between children with CP and without CP. So public health surveillance really is closely integrated with the timely dissemination of these data to those responsible for prevention and control. Next slide. CDC's ADDM CP network. The CDC system for tracking CP is the Autism and Developmental Disabilities Monitoring, or ADDM CP network. The ADDM network was established in 2000, subsequent to the passing of the Children's Health Act of 2000, to monitor autism spectrum disorder and other developmental disabilities. Using this ADDM infrastructure and without any additional funding, in 2002 the ADDM network began collecting and reporting information on CP at 3 sites. The sites that collect information on CP are known as the ADDM CP network. And currently there are 4 sites in the ADDM CP network, which includes areas in Alabama, Georgia, Missouri, and Wisconsin. And you can see those highlighted by the arrows on this map. Next slide. More on the ADDM network. So our ADDM CP network methodology involves screening and abstraction of children's health and special education records at multiple data sources in the community. These include evaluation records of children receiving special education services in area public schools, as well as children served in healthcare facilities. A children is included as a confirmed CP case in our surveillance system if he or she was diagnosed with CP or has a description of physical findings consistent with CP noted in the clinical evaluations at age 2 or older by a qualified professional. A qualified professional is defined as a physician, physical therapist, occupational therapist, nurse practitioner, physician assistant, or clinical nurse specialist. So to determine case status, information is abstracted from health and education records and then reviewed by a CP clinician reviewer to determine if the diagnostic information or the physical findings are consistent with CP. So we have a number of CP clinician reviewers who work with us in this review process, and they are clinicians with advanced degrees, direct clinical experience, and specialized training or certification in the assessment or diagnosis of children with CP. So, for example, a developmental pediatrician, an occupational therapist, or physical therapist. Next slide. You'll see here a diagram that helps to explain the concept of prevalence, which is what we monitor here, the prevalence of CP in the communities that we conduct surveillance in. And this is the total count of children identified as meeting the criteria for CP. That's in the numerator, so the number of 8-year-olds with CP. And then compared to the total population count of 8-year-old children living in the defined surveillance area during the year of study, to determine what we call the identified prevalence of CP for a given year. So we try to count all of the children with CP as best as we can in the given surveillance areas during the given surveillance period, and then compare that to census data for all the children living in that area during that time. And that's what allows us to arrive at our prevalence estimate. Next slide. So I'd like to share findings from our latest report published in the Developmental Medicine and Child Neurology Journal on CP prevalence estimates from the ADDM CP network. The article is entitled Prevalence of CP, Co-occurring Autism Spectrum Disorders and Motor Functioning, Autism and Developmental Disabilities Monitoring Network, U.S., 2008. We also developed a community report available on our website that summarizes the findings from this paper. And again, the website is www.cdc.gov/CP. So as the title suggests, our current report is based on children who were 8 years old and living in the 4 ADDM CP network sites in 2008. Combining data across the 4 sites, CDC estimates that 1 in 323 children was identified with cerebral palsy. These findings support that CP remains the most common motor disability in childhood, and that children with cerebral palsy and their families continue to need support. Next slide. So in this slide, we can see the individual prevalence estimates for the 4 study sites. So the overall prevalence estimate was 3.3 per thousand, or 1 in 323. But as you can see, the prevalence in the individual surveillance sites varied from 2.9 per thousand in Wisconsin all the way up to 3.8 per thousand in Georgia. And the reasons for that variation are not completely clear. They may have to do with different distributions of risk factors, and then they also may have to do with different the balance of the different sorts of sources that we go to at the different study sites. Next slide. So in 2008, similar to previous study years, we found that CP was more common among boys than among girls. Next slide. And also similar to previous study years, we found that CP was more common among Black children than white children. On the other hand, Hispanic and white children were equally likely to have CP. Next slide. The most common CP type overall was spastic CP at about 78%, with bilateral spastic CP accounting for over half of all cases. Next slide. Here I'd like to talk about the co-occurring conditions that we look at in the ADDM CP network. So among children with CP, we look also for information on co-occurring epilepsy, and we also use our ADDM methods to conduct surveillance on ASD to conduct that surveillance among children with CP. So in 2008, about 41% of the children with CP had co-occurring epilepsy, which is very consistent with other population-based reports in different parts of the country and different parts of the world. And interestingly, nearly 7% of the children with CP in our CP network had co-occurring autism. or autism spectrum disorder. And since the overall prevalence of ASD among children in the U.S., is around 1 to 2% in our studies and in national surveys, it seems that the prevalence of ASD among children with CP is considerably higher than among their peers without CP. I mentioned earlier that there's been increased recognition of co-occurring behavioral issues among children with CP, and so we think it's really important that we're able to monitor co-occurring ASD, at least, among these children, and hopefully help to raise awareness among clinicians that having CP doesn't protect you from having other kinds of disorders, and that the co-occurring disorders and conditions can really present, kind of a formidable obstacle, and increase the challenges to function and participation in the community, and so they need to be treated along with the child's motor issues. And as far as I know, we're the only population-based surveillance system to monitor co-occurring autism spectrum disorder among children with CP. Next slide. We also collect data on gross motor function based on information that's available in the records from when the child was 4 years old or older. Clinician reviewers assigned a gross motor function classification system level based on the gross motor skills demonstrated through self-initiated movement with an emphasis on sitting, transferring, and mobility. And from this information, we were able to describe walking ability for children. Next slide. So as you can see from this pie graph, over half the children we identified with CP could walk independently, almost 60%. And about a little less than a third had limited or no walking ability. Collecting information on gross motor function can help us track the prevalence of functional subgroups in children with CP. It can also help inform service needs and be used in economic analysis for program planning and policy development. And I'll tell you that it really came up as an issue during the flu pandemic that we had a couple of years ago, because children with CP, especially those who have very compromised motor skills, are at a higher risk for complications from a respiratory infection. And so they were really prioritized for prevention and treatment of influenza, and they're included as a high-risk group in the recommendations that CDC makes for prevention and control of influenza. And so we were really, this was very good information to have, because people wanted to know, well, what's the proportion of children with CP who, have limited or no walking, because those are the children who are really going to be at the absolute highest risk. Next slide. So it's more than just a prevalence number. The data from our CP network tell us more than the number and characteristics of children with CP, as important as that is. For example, let's think about causes and prevention. Next slide. And then the next slide, risk factors for cerebral palsy. As I mentioned before, we still have a lot to learn about the causes of CP. The majority, or somewhere between 85 and 95% of CP-related neurologic damage happens before or during birth, and in many cases, the specific cause is not known. Some things increase the chance that a child will have CP. These are called risk factors. And it's important to bear in mind that having a risk factor does not mean that a child will have CP. It means that children who have this factor have an increased risk of having CP. So some of the risk factors for congenital CP are, for example, low birth weight. Children who weigh less than 5.5 pounds or 2,500 grams at birth, and particularly those who weigh less than 3 pounds 5 ounces or 1,500 grams, have a greater chance of having CP. And similarly, children who were born before the 37th week of pregnancy, and particularly those who were born before the 32nd week of pregnancy, have a greater chance of having CP. We know that intensive care for premature infants has improved a lot over the last several decades. Babies born very early are more likely to live now, but many have medical problems that can put them at risk for CP. multiple births, twin, triplets, and other multiple births have a higher risk for CP, especially if the baby's twin or triplet dies before birth or shortly after birth. We know that some, but not all, of the increased risk is due to the fact that children born from multiple pregnancies are often born earlier with low birth weight, or both. We also know that assisted reproductive technology, or ART, children born from pregnancies using these infertility treatments have a somewhat greater chance of having CP. And most of the increased risk is explained by preterm delivery or multiple births or both, since both of these are associated with both ART and CP. Something that we've learned in more recent decades is that infections during pregnancy are associated with the risk of CP. Infections can lead to increases in certain proteins called cytokines that circulate in the brain and blood of a baby during pregnancy. These cytokines cause inflammation, which can lead to brain damage. Fever in the mother during pregnancy or delivery can also cause this problem. Some types of infection that have been linked with CP include viruses such as chickenpox, rubella, or German measles, and cytomegalovirus, or CMV, and bacterial infections such as infections of the placenta or the fetal membranes or maternal pelvic infections. Another known risk factor is jaundice and kernicterus. So jaundice is the yellow color that's seen in the skin of many newborns. It happens when a chemical called bilirubin builds up in the baby's blood because the baby's liver is immature and doesn't process it as well as it will later on. When too much, many babies have a little bit of bilirubin, but when too much bilirubin builds up in a new baby's body, the skin and whites of the eyes might look yellow. And when the severe jaundice goes untreated for too long, it can cause a condition called kernicterus, which can cause CP and other conditions. Sometimes this can also result from ABO or RH, blood type differences between the mother and the baby. These cause the red blood cells in the baby to break down too fast, and the baby's liver can't process it, which can lead to jaundice. There are some other medical conditions in the mother, like thyroid problems or intellectual disability or seizures, that slightly raise the risk of having a child with CP. And then finally, birth complications like detachment of the placenta or uterine rupture or problems with the umbilical cord during birth can disrupt oxygen supply to the baby and result in CP. But one of the things that's happened in CP research over the past couple of decades is that we've realized that, I think before people really thought that quite a lot of CP occurred during birth, and we have found that that's really not the case, that probably the majority occurs before the child is born. Next slide. Now, there's also acquired cerebral palsy. A small percentage of CP is caused by brain damage that occurs more than 28 days after birth. This is called acquired CP and is usually associated with an infection such as meningitis or a head injury. So meningitis or encephalitis during early infancy, injuries to the brain from a motor vehicle crash or child abuse. And then there's some other reasons why blood flow to the brain might be disruptive. Children, young, even infants can actually have strokes or bleeding in the brain associated with a blood clotting problem or malformation of blood vessels or a heart defect. Or children with sickle cell disease are at an increased risk of stroke and then could have CP as a consequence of that. Next slide. So there are some actions that people can take before and during pregnancy as well as after birth that might help reduce the risk of developmental problems, including CP. And what we recommend before pregnancy is to be as healthy as possible, make sure that any infections in the mother are treated and health conditions are under control, ideally before pregnancy begins. And there's a website listed here, www.cdc.gov/preconception, that can give people tips on how to just maximize the chance that the pregnancy will be a healthy one. Another thing is to be vaccinated for certain diseases, such as chickenpox and rubella, that could harm a developing baby. And it's important to have these vaccinations before becoming pregnant. And then lastly, if assisted reproductive technology and fertility treatments are used to get pregnant, then consider ways to reduce the chance of a multiple pregnancy, like twins or triplets or even higher, such as transferring only one embryo at a time. Next slide. And then things that you can do during pregnancy. Again, we've got another website, www.cdc.gov/pregnancy, to learn how to have a healthy pregnancy, how to maximize the chances that the pregnancy itself will be healthy. And so we recommend getting early and regular prenatal care, both for your health and for that of your developing baby. Wash your hands often with soap and water to help reduce the risk of infections that might harm a developing baby. Contact a healthcare provider if you get sick, have a fever, or other signs of infection during pregnancy. And know in particular that a flu shot is the best protection against serious illness from the flu. And in fact, a flu shot can protect pregnant women and their unborn babies both before and after birth. And flu shots have not been shown to cause harm to pregnant women or their babies. If there's a difference in the blood type or Rh incompatibility between mother and baby, it can cause, as I said, jaundice and kernicterus. So women should know their blood type and talk to their doctor about ways to prevent problems. It's well known that doctors can treat the mother with Rh immune globulin, we call that RhoGAM, at 28 weeks of pregnancy, and again shortly after birth to prevent kernicterus from happening. And finally, talk to your doctor about ways to prevent problems if you're at risk for preterm delivery. Some research has shown that taking magnesium sulfate before anticipated early preterm birth can reduce the risk of CP among surviving infants. Next slide. Let's go on to the next slide after that, preventing cerebral palsy after a baby is born. So after a baby is born, make sure your child is vaccinated against infections that can cause meningitis and encephalitis, including the Hib vaccine and the pneumococcal vaccine. Any baby, not just one from a pregnancy where there might be blood incompatibility, but any baby can get jaundice. Severe jaundice that is not treated can cause brain damage called kernicterus, as I said. And so this is a cause of cerebral palsy that potentially can be prevented. So we have a mnemonic, it's important to act. Ask your baby's doctor or nurse about a jaundice bilirubin test. Create a follow-up plan before leaving the birth hospital. So all babies 3 to 5 days old should be checked by a doctor or nurse. And finally, treat jaundice seriously. And you can go to www.cdc.gov/jaundice to learn more about this. Next slide. More actions that you can take after a baby is born. Prevent injuries. Buckle your child in the seat using a infant or car seat, a booster seat, or a seat belt, according to the child's height, weight, and age. And I don't have a website here, but you can go on CDC's website and get information about that if you go to injury area. Make living areas safer for children by using window guards to keep young children from falling out of open windows, and safety gates at the top and bottom of stairs. Make sure that the surface on your child's playground is made of a shock-absorbing material such as hardwood mulch or sand. Carefully watch young children at all times around bathtubs, swimming or wading pools, and natural bodies of water. And adults watching children near water should avoid distracting activities like being on a computer or a phone. Make sure your child wears a helmet for activities like riding a bike. And of course, never hit or throw or shake or hurt a child. Next slide. So kind of wrapping up, CDC brings a unique public health perspective to studying health issues in large populations. Our CP tracking data on overall prevalence and then characteristics like subtype, co-occurring conditions, and motor function helps to improve our understanding of CP and it helps communities plan for services and develop policies that promote full participation in the community for children with CP. We know that we still don't have all the answers that we need, but we will continue to try to gather as much data as we can to allow us to look at risk factors for and causes of CP, transition issues from childhood to adulthood, and issues around overall quality of life. Next slide. Thank you so much for your attention. And again, for more information, please visit www.cdc.gov/CP. And thank you, Jeff, for the opportunity to present to this group and help people better understand what we're doing about CP here at the Centers for Disease Control and Prevention.
Well, we sure do appreciate you taking the time out of your busy schedule, Daisy, to help us out with this. And I'd like to thank you now, and in just a second, I have a few questions that came through that I would like to give to you to answer.
Absolutely, my pleasure. I'll answer them to the best of my ability.
Perfect.